Welcome as you join today. We'll just let everybody join the meeting before we start formally. Hello to everyone joining. We'll get started in just a moment. It's great to see so many people joining us from around the country. Okay, well, let's get started this afternoon. Excuse me. And hello, my name's Amy Maguire and I'm an academic at the University of Newcastle School of Law and Justice and one of the directors of our Centre for Law and Social Justice at the University of Newcastle. And on behalf of the Centre, I would like to welcome everyone today to this webinar on the right to health. Thank you very much for giving your time to learn more about this hugely important topic for Australia's future. I'm joining this meeting in Newcastle from Awabakal country, and I pay my respects to the Pambalong clan of the Awabakal people and to their elders past and present. I acknowledge all Aboriginal and Torres Strait Islander people joining this meeting and would like to pay some special tribute to our wonderful First Nations law students and youth ambassadors who are bringing so much energy to law reform movements in Australia. The Centre for Law and Social Justice endorses the agenda expressed in the Uluru Statement from the Heart and acknowledges that sovereignty over these lands was never ceded. Our Centre for Law and Social Justice operates as a dynamic hub to drive social justice law reform and policy making, and we're so proud to partner today with the Human Rights Law Centre to present this webinar and to endorse the Australian Charter of Human Rights campaign. And I'd like to acknowledge and thank Danny Fadul, the campaign director at the Human Rights Law Centre, and Saskia Jones, the project officer for the Centre for Law and Social Justice, who have done so much fantastic work to develop and promote today's event. It's wonderful to see and welcome such a large audience joining us today from across the country. And we have three wonderful contributors to our panel today, and I'll just briefly introduce all of them now. Mohammad Al-Khafaji is the CEO of FECA, the Federation of Ethnic Communities Council of Australia, which is Australia's peak body representing those from culturally and linguistically diverse backgrounds. He trained in software engineering and is a former finalist for the Young Australian of the Year. Mohammad was born in Iraq. He and his family came to Australia as refugees in 2013, and he's achieved so much in such a short time. Welcome, Mohammad. Paul Harpur is an Associate Professor and ARC Future Fellow at the TC Burns School of Law at the University of Queensland. He's a leading disability rights legal academic and the 2022 Blind Australian of the Year. And Paul's current fellowship is focused on disability inclusion in the workplace, and he serves as an ambassador for the Australian Human Rights Includability Network. So welcome, Paul. And finally, Keren Adams is the acting co-CEO of the Human Rights Law Centre, having joined the Centre in 2014 to lead its work on business and human rights. Keren has extensive experience as a litigator in human rights cases, including on behalf of refugee clients and communities impacted by pollution caused by resources companies. Welcome, Keren. And thank you to the three of you for forming just such a fantastic panel. I'm so excited for our discussions today. To our audience members, throughout the webinar, please feel encouraged to submit questions for our panel using the Q&A function that you'll see in Zoom. And later in the session, we'll have time to take some of those questions to the panel. And if you wish, you can also select to show a transcription of the webinar, and you should see that option at the top of the screen. To begin our discussion today, I'd like to ask each of our panelists to briefly reflect on the right to health and its significance. Can I ask which of the three of you would like to begin this discussion?
I'm happy to go first, Amy.
Thank you, Keren.
So the right to health, I think, it's really one of the most fundamental human rights recognised by international law, and it's essential for the realisation of many of the other human rights that we hold dear. So the right to life, to an adequate standard of living, to education, to work, among other things. And the right to health, as defined at international law, is not the same as the right to be healthy. It means that everyone should be able to enjoy the highest attainable standard of physical and mental health. And that as part of making that a reality, that governments have to take steps to ensure that all people, regardless of their status or their circumstances or background, have equal access to health services. So this is a commitment that many countries around the world, including Australia, have signed up to as part of the International Covenant of Economic, Social and Cultural Rights. But Australia, while it has signed up to this international commitment, has not embedded the right to health in our domestic law. So Australian governments at both a federal and a state level are not currently holding themselves accountable to that standard that Australia has promised to comply with on the world stage. And I think that the reality is that the consequence of that is that although Australia obviously has high standards of healthcare overall in comparison to many other countries, there are profound inequalities in our society in terms of healthcare and accessibility of healthcare. You only have to open the paper on a daily basis to see examples of this. We've had multiple inquiries highlighting the difficulties that people with mental health problems or people in aged care have accessing health services. We have Aboriginal and Torres Strait Islander communities with a average life expectancy of almost 10 years less than non-Aboriginal people. And that's due in part to significant differences in access to health services, right from preventative healthcare, such as childhood immunisations, through to emergency healthcare services. We have multiple people in the last few years alone die in prisons or in immigration detention due to failures by the state or private providers to provide basic medical care. The elderly, LGBTIQ plus communities, migrant and refugee communities, people with disabilities, homeless people, women and children in this country all face different barriers and challenges to accessing healthcare. And I think that the COVID pandemic, in addition to obviously putting enormous strain on our healthcare services, really highlighted and exacerbated those existing inequalities that exist within our society. And we saw, for instance, that the vaccination rollout happened very unevenly, with devastating consequences for unvaccinated populations, for example, in aged care homes or in some remote Aboriginal communities, among others. So I think that for us, the right to health and enshrining the right to health in domestic law as part of a Charter of Rights is really about putting the right to health at the heart of government laws and policies and services. And I think there's a very big difference between conceptualising healthcare as a right compared to a service which can be cut back and stripped away at any time. Enshrining a right to health in a charter would commit governments to progressively realising this right and having to consider it explicitly when they're making decisions on healthcare related issues. And importantly, it would mean that individuals and communities would be able to enforce this right where they're not able to get healthcare that they need. And that's why we've been campaigning for a National Charter of Rights to enshrine this right, as well as other fundamental human rights in our law. And we have over almost 80 organisations now signed up to this campaign, and I'd really encourage everyone on the call today, if you haven't checked it out already, to visit the website charterofrights.org.au and to sign up to receive regular updates about the campaign and get involved.
Thanks very much, Keren. In the Centre for Law and Social Justice, we recently hosted a film screening of the documentary Incarceration Nation and a discussion afterwards. And Damien Linane, who chaired that discussion, highlighted that there's effectively no Medicare coverage for prisoners in Australia. And I was reflecting on that as you were talking about the various groups of people who just don't have equal access to enjoy the right to health here. Thanks very much. Mohammad or Paul, do you have anything you'd like to add? Just briefly to start us off, we're thinking about the right to health generally and why you think it's significant. Mohammad?
Sure. Look, thanks for having me. And I think Keren kind of covered, and that was a fantastic introduction. I mean, from my perspective, multicultural health has been in the spotlight because of COVID-19. We all know what happened in the Melbourne Towers in southwest Sydney. We all know about the bungled translations that happened, multiple languages in one. And that's where I think communities kind of kicked into action, and we decided that, we can't wait for government to actually create a safe environment for people. Just some stats, through the new recent census, with 52% of people who completed the census were either born overseas or have at least one parent born overseas. About 20% of people speak a language other than English at home. This is not a small number of people we're talking about. This is a significant part of the population in Australia that we haven't adequately prepared for, and we don't have adequate equitable health outcomes for. And COVID-19 just scratched the surface. The recent data that came out of the census also, or the survey, said that people who were born overseas were 3 times more likely to die from COVID-19 than the general population. And if you were a person from Middle East, you were 10 times more likely to die from COVID. So these are some alarming figures that everybody should, learn from and make sure that we have a very concrete plan going forward. Again, this is, health inequalities, facing multicultural communities, and that's a failure of government. And just as an example, during COVID-19, we raised the alarm and we demanded that there is a advisory group set up to hear from multicultural communities. And I'd like to acknowledge some of my colleagues on that advisory group who are tuning in today. And through that advisory group, we've been able to advise on vaccine strategy, on communications, and on data, because we didn't have any data to inform where the effort is required. And we've been able to achieve something that would take years and years, just in a matter of a few months. And hopefully that's a good example of what is possible when people want to actually do something. And so what we're saying is, going forward, government really needs to have a permanent advisory group on all health matters, not just on COVID-19, and needs to have a multicultural health strategy, a very specific, dedicated, consulted strategy that will ensure that multicultural communities are thought of and not an afterthought. And we need to make sure that the whole nothing about us without us actually is implemented in practice. And we don't talk, and it's not just about frontline staff who a lot of them are from multicultural backgrounds, but also all the way to senior executive levels and senior bureaucrats. Because if you actually have those people in those positions, those issues would have been picked up early on, and we wouldn't have to wait for a pandemic and a lot of terrible outcomes for our communities to realize that this was a problem. So I might just kind of stop there, but hopefully that will be an interesting conversation starter.
Absolutely. Thanks very much. And we'll come back to you very shortly to drill down a little further on the issues for multicultural communities. But just wanted to check in with you, Paul, to ask if you had any opening comments around the right to health and its significance. And you're just on mute there, Paul.
There we go. Sorry.
Thank you. That's fine.
That's a perfect opportunity, because nothing about us without us is actually core to this Convention on the Rights of Persons with Disabilities. And the CRPD, which is abbreviated, is what I do a lot of work around, both research and impact and advocacy. And one of the biggest impacts of the CRPD is about how persons with disabilities are perceived in society and their representation. So it was built on the idea of nothing about us without us. And I think the right to health is really an area where this comes to the fore. So people with disabilities were and have been for most of human history, modern history, controlled by medical professionals, disability experts, and essentially had no voice in their own health outcomes. The CRPD was drafted with this understanding that people with disabilities want a right to health, but also want to control how that health is delivered to them. So you get Articles 25 and 26 specifically dealing with health, but more broadly, you get deinstitutionalization as a big agenda item, supported decision-making, and the right to be represented in all decisions that impact upon the community. So that would mean people with disabilities present and employed, not just as frontline workers, but all the way through to management. So we shouldn't have the health system governed by people, a small percentage of the population represented. So you need people, gender, LGBTQI plus, people with disabilities, and people from the core communities really guiding health interventions. Because that's, after all, if you think about those groups, you get to the majority of the population.
Thanks very much, Paul. Mohammad, we'll come back to you now and ask you to give a bit more detail, please, on what you see as the health challenges that are faced by multicultural communities, particularly over the COVID period, but also any comments that you'd like to make broadly about health challenges for the communities that you represent.
Yeah, sure. Look, I think, obviously, multicultural communities are not homogenous. There are some that are, don't need a lot of support. We're talking about health equity here, and we need to recognize there are some community members that need more help than others. And if we go out there and, and say we are the most successful multicultural nation in the world, without actually, implementing policies that actually support that statement, then it's a tokenistic measure. And we saw that during COVID-19, where government at the time came out and said, well, we're doing everything for multicultural communities. We've got 76 languages, information being translated. Well, okay, well, that's all good and well. They're incorrect. They're mixed up with languages, and they're buried deep in Department of Health websites, and they're out of date. By the time, the new advice comes out, it's out of date. So that's the level of thinking that a government is capable of at that time. And we're saying, you're going to miss our communities by a big shot. And what you need here is some significant investment in community development and building trust with community members, because you are not going to be able to reach those communities from top-down model. You need communities invest in communities. They will look after their communities themselves, which is what we did through the Cold Health Advisory Group on COVID-19, which is, I think, a fantastic case study. I think everybody should learn from that, on how community and government can actually work together to try and protect vulnerable community members. But also, we were able to establish through the government a small grants program where communities could apply and say, we want to do this little project with our communities, and let them take charge of what their particular community needs, and we'll support them with a small grants program. At the time was up to about $5,000. I mean, it doesn't do much, but what it does is it mobilizes community. It gives them a sense of ownership of protecting their community. And so this program has been really successful, but it can't be a one-off. We need to know, we need to make sure that a program similar to that has longevity beyond just COVID, because today it's COVID, tomorrow it's some other outbreak, and the day after that it's some kind of climate disaster where you need communities to be able to reach. Obviously, there are some community members that have fear of government, so you can't just assume that every government message is going to reach communities. That's why you need to work very closely with trusted organisations on the ground to be able to provide that assistance and to provide the critical information through trusted messengers. But a lot of these activities are being done very ad hoc, on an ad hoc basis. We need a strategy. We need someone to sit down and think about this from every aspect and make sure there are resources put behind it to ensure that we don't miss a big chunk of the community in Australia. I mean, and also I have to say, we have learned a lot through experiences of First Nations communities here as well. We can't, pretend that, this was all about original ideas. I mean, we've kind of looked at First Nations communities and how they've kind of navigated that complexity. And we've been able to kind of point to say, well, this already exists for, First Nations communities, and how that's been successful. We'd like to pilot that for our communities. So it's their effort and the hardship that they've gone through has made it easier for multicultural communities to try and make the case as well.
Thanks very much, Mohammad. When you were talking there, I was thinking about COVID almost serving as a wake-up call effectively to policymakers in these areas. We've had a crisis rather than the crisis now, and it's a crisis that indicates all of the deficiencies that could be helpfully addressed before a next one. Thanks very much for your reflections. Paul, I'll come to you next and ask particularly about the Royal Commission for People with Disabilities and its findings regarding healthcare for people with disabilities. So it's said, of course, that Australia has a universal healthcare system, but from our reflections already today, what I'm hearing is that that universality is more a theory rather than a reality at this stage. Can you tell us a bit more about the health challenges facing people with disability in Australia, Paul?
Yeah, I guess the Disability Royal Commissions had two big focuses around health. One was the healthcare with people with cognitive disabilities. They had an issues paper released around that, and also some about COVID. But the cognitive disabilities, that was back in December 2019. Then in August 2020, the DRC published their overview, their responses to that issues paper. So that was the people who submitted. And now there was if you read it, there's no surprise. I didn't think there was many surprises in the responses. There's a lack of support for many people with disabilities, particularly with cognitive, and a lot of the treatment is below standard. So those things were no surprise. One of the things I found probably most surprising was that the Australian College of Emergency Medicine, so basically a peak body of doctors, had submitted noting that many people with intellectual disability and autism and other neurodiversities have significant trouble in emergency rooms, overload, noise, it's frantic, and that results in them being unnecessarily exposed to physical and chemical restraints. So I thought that was it was good to see medical people going, hey, look, we know there's an issue. Not that they really had come up with an answer, but the public advocate in Queensland and Victoria expressed concern that people with disabilities are denied access to healthcare because they walk in exhibiting problematic behaviours, and that then they also talked about the way the medical industry overall devalues the lives of persons with disabilities. Now, there's a lot of bigger things around that with Down syndrome and abortion and termination, but they haven't got into that in the DRC that I've come across. They all talked about deeply rooted issues between the health system and the health system and disability services talking to each other. And so you'll see, not that this is DRC, but just last week, actually no, a couple of days ago, the Victorian government's announced an initiative to get more people out of hospital, working with the NDIS to get them out of the hospital into back into the community, back into the homes to try and reduce the time they need to spend in hospital, which people are spending a long time in hospital unnecessarily, which is expensive, ties up hospital beds and not good for people with disabilities. And also the Bill Jordan also had a media release around that as well. But back to DRC, a lot of support for children. Then when they become an adult, there's less support. So it becomes a cliff where you go from support to no support or very hard to access. And then the health system, again, going back to lack of representation in who's running the health system is not people with disabilities, even though they're one of the groups that are almost everyone, I won't say everyone, but a significant percentage of people who are involved with the health system are people with disabilities. Yet when it comes to who runs the health system, they're not present, which is, I think, a really significant problem. Then the COVID-19, from day one, the DRC has been very concerned. They've had hearings on the way COVID-19 rollout was supporting people with disabilities. Government has responded to a lot of the recommendations, but the most recent that I came across was this year. They had a statement of ongoing concern the Royal Commission issued, which was when Omicron was sweeping the country. The DRC, that is, so they talked getting about the lack of regard for persons with disabilities, the significant lack of resources. So a lot of people with disabilities use support workers. I'm blind, so I don't use them very often. But if you, in a wheelchair, for example, one of my friends, he can't get out the front door to work, to education, to go for a coffee until he's got a support worker to help him. Carers weren't able to access homes because of COVID. So it was keeping people not just bedbound, but dangerously bedbound where they couldn't access essential services of life. It gets that bad. And also a lot of informal oversight disappeared, which is something people don't always think about, but how often things are picked up by family members observing it or friends observing something not going right. Well, all of those people aren't in the hospitals, aren't in the nursing homes. So a lot of issues were going unnoticed and unchallenged, which, because they're not challenged, we can't be sure how bad they were, but there were some of the things the DRC has picked up on. And personally, I've had some very good experiences with the healthcare system. So I don't want to say they're all bad, because I've had a number of very good experiences personally.
Thanks so much, Paul. You covered so much ground there. I'm a devoted carer to a child with cognitive disability and chronic ill health, and we've also been very fortunate to access fantastic medical care here in Newcastle. But I am already really apprehensive about that cliff you're talking about that so many reach when they get to adulthood, and all of the paediatric services are pulled away. I'd just like to remind our audience that you're very welcome. If you think of a question as we're discussing all of these issues today, please put that into the Q&A function so that later in the webinar I have the opportunity to raise some of those questions with our excellent speakers. And my next question is directed to anyone on the panel who'd like to contribute. The Aged Care Royal Commission revealed, as we know, horrible situations for older Australians in aged care facilities, and Paul started to flag similar issues just now. What would you all say are the systemic gaps in healthcare for older Australians? Who might speak to that first?
I'm happy to make a quick comment.
Thanks, Mohammad.
Look, I mean, the aged care system is incredibly complex. It's so complex that we need a navigator program to help people actually navigate the complexities of the system. And that in itself is complex. I mean, I'm not sure if people have tried to kind of get into my aged care. If you have a decent level of English language, you still struggle. So you could imagine, people who don't speak English. I mean, there are layers of complexities that when it comes to people from multicultural backgrounds, there are extra layers that people don't usually think about. And sure, people say we provide interpreters, but like that's mentally exhausting for people to go through a third party to try and get information and understand them back and forth. It takes 3 times longer when you're trying to access critical services. And that's and that kind of puts a burden on other family members and so on and so forth. So the system is not equitable yet, and there are some changes that I think fundamentally will change how we do all of that. But also, governments have, funded, for example, specific, aged care navigator programs, which come to an end. They're trials and they've been proven to be successful, but then there is no continuity after that. So we still have a long way to go when it comes to aged care. And it's not just aged care. I mean, we've had similar navigator programs in disability, they're in mental health and so on and so forth. In my opinion, I think they all should be merged into one navigator program that is funded, for a long time, not just this silly, 3-year and we'll see how it goes, because it's all based on building trust with that navigator on the ground, with that organization, whoever that is. And it's a word of mouth that will actually get out in the community to say, hey, I've had a good experience with this person who helped me try and navigate the aged care system, mental health, whatever it may be. But this needs to be a whole of government approach rather than just a one-off thing because, the government made some election commitment and, we've done it and our responsibility is done. So it's really important to really think about these things long term.
Thank you, Mohammad. Paul or Karen?
Bluntly, I think Australia just doesn't care enough about its older population. I mean, I don't like to be, I'm not old, so I can probably speak a bit more bluntly. But I think what happened during COVID was very concerning. Could you imagine if it was another group of the population that was forced to lock down in a very dangerous situation like that? I just don't. And when people were getting COVID left, right, and center, and there was hospital beds available, there was no talk of taking the people out and isolate in a safer situation. It was just in Sydney, and they saw these. It was an outbreak, and that they tried to deep clean a place and it wasn't working yet. They still kept the people there. If it was, say, for example, a boarding school with kids, would they run it that way? Or if it wasn't if it was a community we cared about, would we have done that? I think it's just there's not enough care, and that's not very good in my view. But that's just perhaps I'm a bit strong viewed on that.
Thank you, Paul. Keren?
Yeah, I mean, obviously the Royal Commission's final report really found that the aged care system, I think the words they used was besieged with neglect, and really was in need of a complete overhaul. And, I think that the main problems that it highlighted was that the system's very hard to access and navigate, and that too many people don't receive quality care, and that these are sort of systemic issues. And then, to go back to the point that both Paul and Mohammad have made, that those from marginalised communities or communities requiring intensive or tailored solutions, the difficulties that they have accessing the aged care system are just really compounded. That they made a large number of recommendations, 148 recommendations for solutions that are needed in response to that. But I just wanted to highlight the first 2 recommendations that they made were really about placing the right to health at the heart of a reformed and improved aged care system. And the final report actually said that framing the reform agenda as one based on entitlement, i.e. rights, is essential. Approaching reform in that way will focus the interests of the people who need or receive aged care being embedded in all key aspects of the new system, and that will guide policy development and program administration, govern regulatory approaches and workforce development, and inform the approaches to be taken by approved providers to their internal governance. So it's that centralising the people who are meant to be at the heart of this system in decision making by government, which is why we think it's so important that a right to health is established in Australian law. And through a charter. It's not going to solve all these problems. Of course, there are other things that are needed to complement that, but it's an important first step in putting, I guess, the rights of the people who are meant to be at the heart of these systems back at the heart of them, rather than other considerations that seem to govern too many decisions by government in these areas.
Thanks very much, Keren. And you're actually leading right on to what I was going to ask you next. So I wonder if you've got anything further to add on the question of how a Charter of Human Rights might help to deal with the issues that have been raised so far today.
Well, I mean, to use the language of, of health that we're talking about, it's about prevention and cure. I mean, it's about placing a right to health places decisions around the individual at the heart of government decision making around these issues, and that has really important preventative effects. I lived for a long time in the UK, where they've had a Human Rights Act for a long time, and one of the things that people often don't see is that the preventative aspects of that legislation like that can have, because it forces governments to prioritise people's basic rights when they're considering designing systems that are supposed to be about improving people's quality of life. And the second important thing is around enforceability and redress, where things go wrong and where systems are falling short of the standards that people should be able to expect, that people have an ability to actually challenge that. And I think these can have really practical, tangible effects for people. We in Australia, obviously, we don't currently have a Charter of Human Rights. We have charters at the state level in Victoria, Queensland, and the ACT, but the only one of those charters that has a right to health enshrined in it is the Queensland Charter, and that is quite a narrowly focused right, that it's not framed in quite the way that the right exists in international law. But in other countries where you can see that they do have a right to health enshrined in law. So in South Africa, for example, where they've got a Bill of Rights in their constitution, which has an explicit right to health, you've seen some really important cases that have been brought challenging key government decisions that have resulted in very tangible benefits for people. So, for example, in 2002, at that time in South Africa, there were over 4 million people living with HIV/AIDS, and the South African government rejected an offer by a pharmaceutical company to widely distribute for free a life-saving antiretroviral medication that would have helped prevent the transmission of HIV from mothers to their babies. And a treatment action campaign, a coalition of people who were concerned about the implications, that brought a challenge to the Minister for Health and won. And the court ordered, therefore, that the government extend without delay the provision of that antiretroviral medication across the board. And hundreds of thousands of lives were saved as a result of that intervention. So, where people are able to draw on the kind of right to health like that, you can see some really incredible kind of outcomes. And here in Victoria, even though we don't have a right to health currently in the Charter, there have been cases that have been brought on the basis, for example, of anti-discrimination provisions in that. So, for example, there was a case a few years ago of a woman who was 50 years old who needed urgent surgery on her hand because she had developed it's called a contracture following an acquired brain injury. And she'd been waiting for 3 years for an operation, but she wasn't considered a priority because she was over the age of 50. And the situation reached a point where she could no longer use her right hand, and she was in considerable pain, and her doctor had begun discussing the possibility of having her hand amputated. And she engaged an advocate who used the Victorian Charter of Rights to compel a decision that she finally had that urgent medical treatment that she needed to improve her physical health. So these are the kinds of examples of what might be possible if we did have these kind of rights enshrined in our laws. And it shouldn't have to get to that point. Obviously, the more important point is the preventative aspect. And and setting up a system that works properly for people in the first place. But it's very important that where things do go wrong, that that people are able to challenge those kind of decisions.
Mm-hmm.
Thanks so much, Keren. You've shared such a broad picture with us of how a charter could assist in this context. And I'm happy to say that we have probably more questions from our audience than we're going to have time to answer. So I'd like to thank everyone who's been so engaged and has submitted questions. I'll do my best to get a few of them to the panel now. I know one of them was about this question of the breadth of the right to health as expressed in the Queensland Human Rights Act, and you did touch on that, Keren, already. So I might combine a couple of questions first of all, because there are two that focus on privatisation, but they come at the issue from different perspectives. So one member of our audience is a GP who's reflecting on differential outcomes for their patients, in the sense that people with private health insurance find it much easier to get care through GP referrals than those who are relying only on the public health system. Whereas another member of the audience flags the privatisation of aged care as a limiting factor in terms of the health outcomes for older people. So we've got two perspectives there on the issue of privatisation in relation to healthcare in Australia. Who on our panel might comment on that first of all?
I mean, I could personal experience. I broke my ankle playing with my son, running behind him. I'm totally blind, if you didn't gather. He was on a bike, so dumb. Anyway, and in flip flops or thongs, depends what state are you in. So anyway, I have the money to go pay for private health support, so I was able to go to the GP. They said you can get an X-ray, but the public system was going to take ages, or I could pay for it. Got the X-ray, came back to the doctor, who wrote me a referral letter. About an hour later, I had it all fixed up, and I was in a moon boot, and I was at home. But that's because I could afford it. Whereas if you can't afford it, it would have taken months. Well, it could take a lot longer to get that treatment. And in terms of the NDIS, if you can pay for a private surgeon, private psychologist to get onto the NDIS, you'll get on very quickly. If you can't, and you're waiting for a public health doctor to write you a letter that explains and fills out the form correctly, it's very challenging because GPs aren't really remunerated to spend an hour and a half filling out a complicated bureaucratic form.
Thank you, Paul. Mohammad or Keren, would you have anything to add in the context of privatisation?
I think that I think it's obviously it's variable, the impact of privatisation in Australia, and because we privatise certain things and not others. And I always kind of reflect on this because I have lots of family in the US where the system is far worse, and sort of seen the kind of the extreme that can happen where people are, prior to Obamacare coming in, for example, my aunt and uncle, both of whom had mental health issues, were completely unable to access any form of health insurance, and were really cut off from the most basic forms of healthcare in the US. And then having lived in the UK as well, where it's a far more public system than in Australia, you can see that the huge benefits that come from being able to just access care when you need it, irrespective of your ability to pay. No one ever knows the lottery that they're going to be dealt in life, and that's why we shouldn't have to, you shouldn't have to rely on having a certain job or being able to afford cover in order to access kind of basic healthcare. And I think that putting a right to health at the centre of our laws would actually require governments to prioritise this in the way that they're currently not required to prioritise it.
Thank you, Keren. So many fantastic questions coming in, and I apologise in advance because we certainly won't be able to address all of them in the last 15 minutes, but let's ask a few more at least. A question here, and a thank you to all our panelists for an excellent session. This member of the audience is noting that so far the discussion has focused on a right to access healthcare as it's protected in the Queensland Charter. And the question is, do you think that a campaign for a Charter of Human Rights should be limited to a right to healthcare? Or should a Charter of Human Rights in Australia take the broader approach of including a right to health and also protection and provision of the determinants of good health? Keren, would you like to start with that one?
Yeah, I mean, I think it's, you know, it's unfortunate that despite the fact that many of the economic, social and cultural rights, so things like right to health, to education, and the like, are ones that repeatedly people say are some of them the most important rights to them when people are asked to kind of prioritize that. It's unusual that the rights to those economic, social and cultural rights are prioritized within charters. So most of the charters that have been implemented to date have focused heavily on civil and political rights, so things like the right to vote, right to protest, right to a fair trial, things like that. And I think it was a really positive step to see Queensland when it introduced its charter, including some of the economic, social and cultural rights. I think definitely if we had implemented a federal charter, there should be much stronger consideration given to including the full range of rights, including the economic, social and cultural rights that we are committed to under international law. There is no reason to, governments have always been very hesitant to implement those because of the resourcing implications that come along with that. But, international law obviously takes into account the fact that that states have limited resources, and that those rights need to be progressively realised over time, and that's where resources are greater, there is a greater expectation that those rights will be realised and will be provided. But I think not having them means that we're really missing out on some of the really key fundamental areas, that some of the ones that we've covered, like aged care, like disability rights and things in Australia that are not being properly prioritised and considered when governments formulate their laws. So I guess to come back to that question on Queensland, yes, we would have liked to have seen a broader right, and I do think it should be more consistent with Article 12 of the International Covenant on Civil and Political Rights if we head down that path. But I think it's positive that Queensland has implemented that, and it's a good start, and it's something that can be built on.
Absolutely. And of course, we have other jurisdictions in Australia, including New South Wales, where I'm based, also actively engaged in these subnational efforts to improve human rights protections for more people in our country. Personally, I think all of these efforts will combine over time to generate more and more momentum for the national campaign. Just noting a comment here, and Mohammad, it may be that you'd like to speak to this, or it may just be a comment from a member of our audience who notes that refugees arrive in Australia with profound strengths, but that the settlement system doesn't enable health equity because they often have reduced ability to communicate their symptoms and may have different thresholds for seeking care. Is there anything that you'd like to add to that comment?
Look, the refugee health in Australia is very good, and there are people on this call actually who do really amazing work to try and improve refugee health. I mean, there is this healthy migrant effect that anyone that comes to Australia is required to be healthy, and all of that jazz. So there is that kind of phenomena. But going forward, the issue of cultural sensitivity around some of these issues, the issue of language, the issue of accessing the system, are things that I don't think we have done enough thinking around to ensure that we reach that particular population when it comes to other health outcomes. I mean, a lot of migrant communities don't want to kind of go to GPs or don't want to rock the boat or be a burden on the system that's welcomed them here in Australia. And I think we really need to do a lot of work to make sure that those people feel comfortable to come forward and seek help when they need to. I mean, there are a lot of health issues that are culturally sensitive, especially for a lot of people who, back home may not have discussed them, whether it's, menopause or childbirth or whatever they may be. There is a piece of work that needs to be done through trusted community partners to ensure those things are discussed. So given that context, what we've seen in Australia, because we can't basically sit back and wait for government to tell us we've got an answer for everything. No one has, you look at Aboriginal health, they've been fighting for this space for a very long time, and they still have to fight for it, even if there is a government support for it. What we've done at FECA, because of COVID, we've realised that COVID is only a small part of a problem, and we know there is a big problem with it. And we know that the same problem exists in other health-related issues, but we just don't know what they are. So what we've done was to establish this initiative called the Australian Multicultural Health Collaborative, which aims to bring health practitioners, researchers, service providers, consumers together, so they can inform us about what are the priority areas that we need to look into. We don't know what we don't know, but we're great advocates for our communities, and we're happy to, kick down a few doors and say, you need to fix this. But we need those people to tell us exactly what is the problem and what needs to be our focus to make sure that we reach parity and we can advocate on those health issues going forward. So the collaborative is free to join. I'm got to give it a plug. If you care about multicultural health, if you work in multicultural health, whether you're a researcher, practitioner, service provider, would love for you to join the collaborative and be part of the journey with us.
Thanks very much, Mohammad. I think we've got time for two more questions from the audience. One is from Andrea Lucas from the McCabe Centre for Law and Cancer, and an interesting question that we haven't touched on so far in the discussions. Andrea asks, how can the right to health in Australia be realised to better and adequately address the burden of non-communicable diseases, including chronic diseases like cancer and diabetes? Anyone happy to address that one? I know it's a big question.
Well, I mean, broadly speaking, the right to health applies equally to whether it's a communicable disease or any health conditions. I mean, cancer survivors, there's often that challenge that they can come within under the CRPD in certain circumstances, but they're not in others. I mean, that's not really much help, but I just think it's I think we shouldn't focus on the flashy COVID, because today it's COVID, next year, hopefully, touch wood, COVID's no more here, that we still got the same issues of health. So I think we need to focus on longer term initiatives around the right to health while the momentum's here.
Thanks.
And just quickly, if I can add to that, so Cancer Australia as an organisation, they've reached out to FECA to try and, while they've kind of developing their cancer strategy, they've really kind of started engaging really at the early stage, rather than saying, here, we've developed a strategy, what do multicultural communities think of it? They've actually engaged right from the start, and that humble realization that we need communities to come along with us and inform us. So that's been a gold standard, in my opinion, in terms of how you actually engage communities to inform government strategy. But that's only one government agency, if you like. There are many other government departments and agencies that need to do the same. And if we can encourage them to do that, we'd love to support anything. And that's basic kind of engagement principle. And it's not unique to multicultural communities. It's the same with First Nations communities, people with disabilities, LGBTIQ+, and so on and so forth. I think where this actually happens is when there is those organizations' leaders actually believe that we need to engage right from the start and actually believe in the whole nothing about us without us kind of principle. So I just want to kind of commend those organizations who engage early and engage often.
Thanks very much, Mohammad. And going to what Paul was saying, I think it's really interesting how the nothing about us without us language is clearly shared across health advocacy and disability sectors. And I know through my family's experience that several chronic diseases, including, for example, epilepsy, are difficult to fit into disability categorizations, for example, through the NDIS. But people who live with those conditions tend to live with disability as well. And our systems can really improve in terms of understanding the interaction between a health condition and a person's lived experience of disability. We're very close to time, and I must apologise to everybody who hasn't yet had it, or whose question I didn't get to put to the panel. A final question to take us in a different direction. What appetite do you all observe among policymakers and governments to make the sort of systemic changes that you've indicated are necessary in this context?
Well, we had maybe I'll go first on that one. We had a great session on this very kind of issue in terms of particularly in terms of the potential for a national charter of rights a little while ago. I think we're obviously we're in a really optimistic moment at the moment in Australia in terms of the possibilities. I think for so long, so many of us have been engaged in battling constant kind of attacks and haven't been able to think about a more proactive agenda. And I think the current government, including the new crossbench as well as the federal Labor government, really presents a real opportunity, I think, for thinking about things like a national charter that are positive, advancing a positive human rights agenda in Australia, rather than simply small piecemeal pieces of legislation where that's possible. So I really hope that we can use this opportunity and take advantage of this to kind of push forward some really wide-ranging reforms, including a charter of rights. And I'd encourage anyone who hasn't done so to, especially whether you're interested or not in joining the campaign, there's some fantastic resources on the Charter of Rights website, including some specific reports about the right to health in Australia and realising the right to health. And we're about to produce a new fact sheet, which will shortly be going up on the website as well, specifically on the right to health. So encourage everyone to take a look at those and get involved in whatever way you can.
Thank you, Keren. Unfortunately, I have to wrap up. I feel like we could keep talking for hours, and you've all brought so many wonderful insights to today's event. So I'd like to thank Paul, Mohammad and Keren very much for your expertise and giving your time and input to this event. And also really thank all the members of our audience who took time out of their busy days to engage with this topic. Thank you, Keren, for flagging the ways that people can continue to engage. We will, at the Centre for Law and Social Justice, soon post a recording of today's event online. We'll share those details with people who participated, and we will also be able to share the fact sheet that the Human Rights Law Centre is soon to produce in this area. I encourage you all to think about joining the campaign for an Australian Charter of Human Rights. The website again is charterofrights.org.au. Thank you very much to the Human Rights Law Centre and wishing you all a really healthy week ahead. Thanks very much.
Thank you. Thank you, everyone.
Thanks so much. Thanks, Amy.